Welcome, and thank you for joining us today for the webinar on improving the reach and quality of cancer care in rural populations. My name is Jennifer, and I will be your WebEx host. Before moving into introducing our speakers, I'd like to cover a few housekeeping details. All attendees will be in listen-only mode. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the drop-down. We will ask as many questions as time allows during the Q&A portion of the webinar. If you need to view live closed captioning, please refer to the Media Viewer panel. This webinar is being recorded and will be posted online in the near future. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. And now I'd like to turn it over to our speakers, Dr. Bob Croyle, Director of the Division of Cancer Control and Population Sciences at the National Cancer Institute, and Dr. Shobha Shervina, who is the Health Disparities Research Coordinator in the Division of Cancer Control and Population Sciences at the National Cancer Institute.
Hi, everybody. Bob Croyle. Thanks for joining, and thanks for your interest in this RFA. I'm just going to give a couple of background comments, we've been receiving a number of questions about this RFA up until this point, too. And so we'll be kind of getting to some points later on that address those domains. So starting with the most obvious, and that is NCI's motivation for doing this RFA, this initiative. And I'm not going to restate the whole presentation that we made to our Board of Scientific Advisors, but just to be clear that across the whole varieties of health disparities research that NCI supports, we're constantly looking at data trends, incidence mortality trends, behavioral risk factor trends, trends in healthcare delivery and access. So monitoring lots of different types of data and use these data to help set our priorities. And so this is a data-driven priority in the sense that it's one health disparity domain where this disparity is getting worse, not better. So the spread between urban and rural mortality rate in particular. Also, one of the points I've made, and some of you have heard me speak in many different venues about this, is kind of the relationship to national goals, public health goals. This is just using healthy people as one example, and the kind of the growing distance between progress between, in this case, metro, non-metro comparison in terms of achieving reductions in cancer rates. One of the things that was clear in the discussion leading up to the development of this initiative is we did, originally start out with kind of a much broader agenda and the whole cancer control continuum, but ultimately developed an RFA that's focused on cancer care. And that'll come up repeatedly, I know, because a number of folks have expressed interest in more applied public health upstream issues. This is not that. This is really focused on cancer care delivery. And so the title of the RFA needs to be taken very seriously, reach and quality of cancer care. So our other speakers will come back to that and emphasize that, but I wanted to mention that at the outset because I know there's a temptation to say, well, I study square blocks, and so I'm going to put it into this round hole, and there's often a temptation in any RFA reissue for people to utilize the RFA to support the work that they already want to do and they're already doing. If we already had a relevant large portfolio in rural populations in cancer care delivery, we wouldn't be doing the RFA. So this is really to fill a gap in our portfolio and also to encourage more people to get into this research domain. So that, I'll pass it over to Shobha, who's been helping coordinate this overall effort to make a few other points before we start to get to your questions as they come in.
Thank you, Bob. So I'm going to go over the goals of the RFA, which I will repeat as the title says, is that it is to reduce the burden of cancer and improve the quality of cancer care in rural areas. So also the emphasis is rural and low income and/or underserved populations. So we are actually focusing on two types of applications here, so you could propose either one. One, which is an observational research that includes pilot testing, or an intervention research. Totally, all the specific aims are based on an intervention that you hope to implement in the community. So I want want to emphasize again, the focus is on cancer care and treatment delivery. So the focus is not on public health prevention. And I know there have been a lot of people calling about it, and there are very good ideas out there. And we do have a whole bunch of FOAs that are relevant for those areas. So going to these observational studies that you could do in this FOA, it is with pilot testing. So you could, in the first few aims, look at understanding the situation and at least have one pilot test aim which addresses the predictive or mediating role of issues or barriers to care and treatment. The budget for this is not to exceed $400K in direct costs for any of the 5 years. Also want to point out the entire FOA does not focus on issues related to recruitment and retention of participants to clinical trials. Now, if you're focusing on intervention studies, we do understand that most intervention studies are not ready for implementation, so you should seek to develop, adapt, and/or implement and test interventions. So we are hoping that you could come in for less than $500K in direct costs for any year for 5 years. Again, it's not focused on recruitment and retention of participants to trials. So I want to give you a couple of things that we are requiring people to do within this FOA. You are required to use the Rural Urban Continuum Code, RUCC, and go for the 4 to 9 code. 4 begins with the rural, and 9 is the most rural areas that you would have. You also have to pick a population that has a low income and justify that population being served is low income. It's not an either-or choice. You have to do both. You can, if you want, also use other definitions, such as the other than the RUCC, if it is relevant to your aims and your study. But you are supposed to use the RUCC to justify this project that you are proposing. So I'm just providing the RUCC Continuum Code used by the USDA. That is the 2013. This is most of you are very familiar with it. The 4 to 9 is the rural area that we are kind of focusing on.
And we just want to emphasize that because so many folks have asked about it. And just to emphasize that an application will not be viewed as responsive to the RFA that does not use these codes, and that, in other words, say that we are targeting a population in a county or in a location that meets this definition.
And also I would like to also emphasize along with Bob that low income is important to justify why this is low income. And actually, if you look at we've provided some websites for you to take a look at, which talk about rural poverty and what the guidelines, the ASPE also has the guidelines for poverty. So I want you to take a look at those because people have come back to me and said, well, my population here is about $80,000 a year and that is low income for this area. I don't think according to the ASPE definitions and the USDA definitions and the US Census definitions, that really falls under the low income category. So I would recommend that you take a look at those websites. So some of the examples that can be covered, it's not necessary that you cover these, are barriers to accessing health services, evaluation of some natural experiments where states and counties are adopting certain rules and regulations for implementation of various healthcare services, the role of social determinants of health, such as factors in trust and attitudes towards institution providers, and others, and limitations in information technology, how this could kind of, with patient portals, telehealth, how can we improve and coordinate care better for cancer patients, IT-enabled systems, how can we develop team-based care delivery models, or to improve primary and specialty collaborative care to enhance any kind of state of the cancer care and follow-up care. So there are a variety. These are not exhaustive. These are just examples of activities that could be covered within it. You could go beyond this or limit it to any one of these. I also want to emphasize the whole area of collaboration. A lot of people have been sending their one-pagers to Sally Weaver, who's here with me, and myself, and we're finding that though they are proposing to work with clinics. They are not bringing the clinics into the conversation or even into the specific aims and assuming that somehow it will get done. So one of the things which is very important is we would be looking into how feasible is a study that you are really proposing to do in these clinics and in these areas. So I would recommend that you take a good hard look at who's going to deliver the care, who's going to coordinate the care, and whether you have made plans organizationally and programmatically to make sure that these interventions are delivered appropriately and can be made sustainable.
We've been meeting with lots of rural health providers and organizations and communities and clinics, and there is a lot of skepticism in the rural health provider community about the degree to which the typical academic investigator understands their context, understands their payment issues, understands their infrastructure, and so there's a lot of concern that there may be a good deal of naivete in terms of what's feasible and what can be done in terms of an efficacy trial conducted within a rural cancer care setting or a cancer care setting serving rural populations. So I think, thinking down the road, reviewers are going to need to be convinced that the intervention design and planning and the engagement of providers is really informing the study design, and that a convincing case is made of that, rather than proposing a trial that's going to impose undue burden and be really infeasible to test and try out in these underserved rural settings.
So I just want to point out to everyone that this is a clinical trials required, so there are various guidelines for this, and please follow those guidelines. CSR, that is the Center for Scientific Review, is getting very, very strict, and if you don't follow those guidelines, they are returning applications. So please be mindful of it, and please look at these various requirements that are there and make sure that everybody goes through the training and it fits within the requirements of NIH's clinical trials. Also, I just want to point out to you that your specific aims is 1 page, your research strategy is 12, your biographical sketches are 4 pages. So please contact me, and Sally and I will get back to you as soon as you have your 1 page, send it to us so that we can have a discussion. I've had people call me up and say, I have an idea, which is great as a phone conversation, but if you put it on in writing, then we can mull over it and then get back to you and we can have a phone conversation about it. So I also want to talk to you about the application alignment. I'm sure most of you know about this. So if the review criteria is significant, they're going to look at your research aim and purpose. The investigators' capability in conducting the study and your partners will be looked at in the bio sketches. So if you are kind of building relationships with new partners, this is somewhere you want to talk about how you worked in the rural areas with different kinds of partners and why this new partnership is also important in doing the kind of work that you're doing in building that partnership. So innovation would be in your research strategy, the approach is in your research methods and analysis, and the environment is in the resources that you have to offer. So all these things put together would become very important in how you would build that agenda, especially in areas hitherto that lots of people haven't done work in for quite some time. So I want to pull some important dates for you. The letter of intent is due August 19th, and it's very good if you could send us the letter of intent with the title and your partners, so at least we can, for planning purposes of how to build a review team, it would help us. The applications are due September 19th. The review will be sometime November or December, and we hope to fund by July 2019. And just as a FYI, today's webinar will be posted on the website, and you can contact us anytime. I would encourage all of you to just at least send me an email and propose any questions that you might have. I just want to say that if you are asking questions today specifically about some data that you already have and not published, I would not do that on a public line, but I would recommend that you drop us an email about that if you don't want to make that data public. Here are some additional resources. We did a workshop by the National Academies of Sciences, Engineering, and Medicine on improving health research on small populations, and the publication is out, which is very relevant for rural cancer control. And we also have a rural cancer control website where you can find more information about the meeting that we had and also other federal publications that would be relevant to your work that you're doing.